Good morning, everyone. We're going to get started, so if everyone could find their seats, that would be great. So on behalf of everyone from the Treatment Research Institute, I want to say welcome and thank you all for being here. This is the first public talk of a series that we've initiated called Translating Addiction Research into Impact. And it's made possible with generous funding from the Reckitt Benckiser Pharmaceutical Company as an unrestricted educational grant. So they've given us the money and said that we can do whatever we feel is the right thing to educate the public about this issue. We're honored today to have an outstanding group of presenters with us to talk about the importance of the Parity law and, more importantly, the importance of full implementation of the law. We're going to start off today with a talk from the Honorable Patrick J. Kennedy, who will be properly introduced in just a moment. Representative Kennedy's presentation will be followed by a panel discussion today, which is going to be moderated by Maiken Scott, WHYY's behavioral health reporter, and the producer of The Pulse, a new show about innovation in health and science. Our distinguished panelists include Carol McDaid, who worked alongside Representative Kennedy to advocate for parity legislation and was a key force in many of the policy advances in mental health and substance abuse care over the past 2 decades. In addition to being a principal at Capital Decisions in Washington, D.C., she's the co-chair of the Parity Implementation Coalition. We're also joined by Paul Samuels, who's the president of the Legal Action Center, a nonprofit organization that has been pivotal in advocating for the rights of people with alcohol and drug histories through groundbreaking litigation and advocacy campaigns. And finally, we're honored to have our very own Arthur Evans, Philadelphia's Commissioner of the Department of Behavioral Health and Intellectual Disabilities, in which he oversees the mental health services for the city and ensures that these are coordinated with other key sectors, including justice and education. If you have any questions for Representative Kennedy or any of the panelists, please write them down on the index card that's included in your folder, and staff will be circulating after the presentation and during the panel discussion to collect these. Also, for anyone who's interested in obtaining CEU credits but hasn't already registered for these, just see someone at the end of the talk outside at the registration desk and we can get you set up. And very importantly, if anyone needs a restroom, they're in the back or the front of the auditorium and to the right. So without further ado, please welcome Tom McClellan, CEO of the Treatment Research Institute.
Thank you, Abigail, and thank you all for coming. I'm very excited about today. First, a word about TRI. We are now celebrating our 23rd year where my colleagues and I are trying to take research, but not stop with that published article, but instead translate it into practical, useful, impactful tools, services, and policies to change behaviors in the addiction field. And this award is given, this inaugural award is given for just that purpose, to celebrate somebody whose work has done exactly that kind of mission. It celebrates the career of someone whose work and whose impact exemplifies exactly what that mission's all about. So to envision it, just imagine if you had care for diabetes delivered under the same conditions that care for addiction has so long been delivered. It would be time limited. You'd have 30-day diabetes programs. It would have all manner of copays. You would have to be pre-certified. You would be at the whim and the caprice of an insurance company that didn't have to tell you why they were discontinuing your care. Many of the FDA-approved medications and services would not be available to you because they simply decided that. Well, Patrick J. Kennedy saw beyond that. He saw a world where that didn't have to be the case, and he became one of the major architects and the most public and tireless advocate for the Mental Health Parity and Addiction Equity Act, the Parity Act. And it promises to give, finally, the end of segregation of the addiction and mental health field from the rest of mainstream healthcare. So Congressman Kennedy, I think, I may have this wrong, but I think he is the youngest elected public official in Rhode Island at one time. And he served for 16 years in Congress. He is the architect and, excuse me, most public advocate for the Parity Act. And since his retirement from Congress, he has not stopped one bit. He is the founder of two organizations, One Mind for Research and the Kennedy Forum. That's a catchy name. I don't know where you figured that out, but the Kennedy Forum on community mental health. These two organizations have one real mission: advocate for, find new and better treatments for addiction and mental health. So there frankly is no better person in the United States whose work and whose career has embodied what this inaugural award stands for. So please help me welcome Congressman Patrick J. Kennedy. I think we're supposed to look pretty here.
Let's go walk over right here. Thank you, Tom. And there's a reason I named it the Kennedy Forum. I got elected as the youngest member of the Rhode Island State Legislature at 21. And then I got elected to the United States Congress as the youngest member of Congress at the age of 27. And then I got elected by my Democratic caucus to be in the leadership of the whole Democratic Party at the age of 31. And none of it had to do with my last name being Kennedy whatsoever. It was my good looks and personality that, skyrocketed me right to the top. So there is something very powerful about this last name, Paul Samuels. I mean, I hit the lottery when I was born. I got that great dint of birth. I had nothing to do with it. I just arrived in this world and was given this great family legacy that was bestowed upon me. But I've been blessed because I had an amazing father who conveyed to me that with this great opportunity of having a last name like Kennedy, I had to use it for social good. And clearly the real test, as my father always said, for a society is whether it expands the circle of opportunity for more and more Americans. And of course, that has been the narrative of my family's history. Whether it was John F. Kennedy being the first president of the United States to go on national television on the issue of civil rights and say, who amongst us would trade the color of their skin and then be content with those who say, wait. He actually said, would be content for those who counsel patience and delay. In other words, back in the civil rights era, they said, don't rush civil rights. We'll get there. Take your time. And John F. Kennedy hit the issue square on, and he said, who amongst us would walk in the shoes of another American who simply because of the dint of color of their skin was not treated equally in this country. Rather, they were treated as a second-class citizen in this country. In other words, let's apply the golden rule. Treat others as you yourself want to be treated. And of course, my Uncle Bobby continued that march towards progress. My father worked for nearly 5 decades in the Senate to advance that cause. And the last bill that my dad and I worked on together, the last bill my father saw signed into law was the bill that he co-sponsored on the Senate side, with taking over for the late Paul Wellstone with Pete Domenici. And that was the Mental Health Parity and Addiction Equity Act. And I had the chance to work with him on that. It was signed into law by a Republican president, so there's no confusion here. this issue is bipartisan. And of course, these issues affect all Americans from every walk of life. It's a shame you even have to say that these days in order to bring this to this tragic conclusion that our democracy today is severely broken, and our ability to make progress is often hindered by these partisan and personal divides. In mental health, it's all personal. It affects every single family in America. None of us is exempt, and we as a nation need to get our head out of the sand and start thinking about how we're going to treat one another with dignity and respect. Because these issues aren't just medical issues. These are issues, as Tom said, go to the core of who we are as a people. Whether we honor one another or whether we discriminate against one another. You know, and how many of you would like a system of care, as we currently have, that dismisses, disregards, discriminates, and marginalizes the very people who it's supposed to take care of? So what we have, as Tom said, with the civil rights notion, is we have a separate system of care. We have a health care system, and then we have a mental health care system. Does this not sound familiar? Justice depends on geography. If you want treatment, go down the hall. Drink from the colored water fountain. Go to the colored counter. You don't belong here in health care. You got to go down and be treated by professionals who are paid a fraction of what they would be paid if they were treating you in the rest of the healthcare system. You're told that your illness is not real and that you are at fault for your illness, because the idea is that this is a moral failing, not a medical failing. That this is a failing of character rather than a failure of chemistry. So, my friends, I got to be the sponsor. I'm honored to be given this great recognition, especially from TRI, and the fantastic work that both Tom, Maiken, and all of you here have done. Abigail, congratulations on pulling this together. But the notion of this is all about how we're going to reintegrate healthcare so that we treat all diseases the same. Hence the word parity. Equality. I can't emphasize for all of you who are interested in this field how we need to, in this world, explain our mission quickly and succinctly. Because part of our problem in the mental health, substance use disorder, severe mental illness, intellectual and developmentally disabled community. I mean, come on, we're going to be like here all day going through the anachronisms to describe who our community is. Okay? We're all of us. Okay? We're all of us. I got a little bit of this and a little bit of that. Where do I fall? Do I fall in the substance use system? Do I fall in the mental health system? I got a TBI. Do I fall in the, physical neurological system? I mean, this is unbelievable. You cannot make up this system of care if you were really trying to design a bad system that hurts people more. You really couldn't, if you put your mind to it, probably couldn't come up with an even better system than what we have today in terms of what it does to patients. So the challenge is this notion of equality. That's what I say. Obviously, I'd like to have more for mental health, and of course, with the advent of medical management and everybody trying to push down costs, this is not necessarily a good thing for mental health and addiction, because we know investment in mental health and addiction pays results in the rest of healthcare, in addition to into the lives of those who are affected by these illnesses. So we don't want just the same. I'm just speaking partisan-wise. I want more than we're giving today in physical health care. But for the purposes of our political discussion, let me set the bar pretty clearly. This is about we demand no less, as Tom said, than the diabetic, than the asthmatic, than the cardiovascular disease patient. We just want the same. Because when we go outside today and we go out into the world and try to explain what is this cause of mental health, all you need to say is it's about equality. Americans get that. They don't like the notion of discrimination. We need them to understand this is simply about discrimination. And discrimination is born on prejudice and bigotry. And where does that come from? It comes from lack of knowledge. It comes from confusion and misunderstanding. So I'm honored to accept this award because TRI is about eliminating that confusion. It's about bringing transparency and understanding about mental health and addiction such that it isn't seen as something else, but rather is seen in the same world as the rest of healthcare. So I get all this credit. People like Carol McDaid and I, we go around. You know, everybody gives me credit for being the sponsor of mental health parity. But I'm here to tell you, it's by default that I'm the sponsor. Because you see, as I said at the beginning, I was the youngest member when I got elected, meaning I was at the lowest end of the totem pole seniority-wise. I didn't have as much hair as Tom or as much gray hair as Tom. Usually people who have a lot of gray hair or not much hair at all are the ones that get to sponsor these bills because it usually means that they've been around a long time and they have seniority. And so here I am, a young member of Congress, and I got to be sponsor, which indicates to all of you, just so you understand, how popular the Mental Health Parity and Addiction Equity Act was in the United States Congress, because it wasn't as if there were senior members falling all over themselves to get their name first. And you know politicians, we like to take credit for popular things. So we're rushing to get our names first, but somehow most members didn't like the idea of having mental health and addiction right next to their name. It kind of like got them a little uneasy. They said, well, what's going to happen if this reporter asks me whether, you know, I've got a mental health problem or addiction problem? So that's why this thing did not move. So the elephant in the room is we've got to address this kind of big issue of our attitudinal barriers that's leading to this separate system of care and this discriminatory practice. It's the big elephant in the room. And that elephant in the room isn't just in our living rooms, because those of us, like myself, who've grown up in a family struggling with a mental illness or addiction, know that you don't say anything when you grow up in that kind of family. You just keep quiet. And you know what? That's exactly what's happening in our nation's living room. That's what's happening in our country right now. If we're the American family, we got mom or dad who's got intractable addiction or depression. We got a sister or brother who's dying of a mental illness, and none of us is saying anything. That is the situation right now. So it's not only in our own lives, it's in our nation's life. And it's the same problem. We need to talk about it in order to expel this bad feeling that currently pervades the dialogue around mental health and addiction. So that is the challenge. Now, we got to move the bill finally because through kind of legislative chicanery, I'm sorry to say that sometimes backroom deals work out for the best. My dad's best pal, Chris Dodd, got to put the mental health, his TARP bill, you may recall that $800 billion bailout for the banks. He attached that bill to H.R. 1424, the Mental Health Parity and Addiction Equity Act, which means you're looking at not only the sponsor of Parity, but the sponsor of the largest bailout of the biggest banks in our country. So I'm this really awful guy right now because I gave Jamie Dimon like a couple $100 billion. Like, who wants to give Jamie Dimon that money? I mean, he lost it all, and now we bailed him out. So that's how but that's literally how we got parity, because we had a financial crisis, there needed to be a bill to fix it, and we got it attached to the parity law, and hence it passed, which means most Americans don't know this is the law of the land. So our job is to try to take this out to the country and explain to the American people there is a federal law. It applies to not only insurance companies, it should apply to the government itself. It should apply to the VA. It should apply to the Department of Defense. It should apply definitely to Medicare and Medicaid, where we still don't have a rule adopting the federal parity law. So what I'm trying to explain to you is our job is to get our message out. But what I love about working with all of you and the fantastic legacy of UPenn and Dr. Charles O'Brien, one of the leading researchers in this field here, UPenn actually has addiction education for every physician coming through your medical school across the street. Wouldn't that be great if most medical schools adopted the UPenn model? That would be one of the things that we'd put on our agenda. How can you have physicians know how to treat an illness as big as this when none of them have gotten training for it? So you understand where we're at? Like, we are like ground zero in terms of all the things we need to do to fix this big system of failure that we're in the midst of. And what TRI is doing, as I said, is taking and organizing the big picture of the message here such that we can all begin to go out there and begin to take to scale what we know works. Because one of the biggest things holding us back is the general distrust that when you talk about mental health, you're talking about something we really don't know how to treat. When what we're really seeing in the past is that we've paid for the wrong things. And you pay, you get what you pay for. You ever hear that saying, you get what you pay for? We get in this country what we pay for. So if all we pay for, to take Tom's great analogy to having diabetes, we are equivalent just paying for the amputations. That's how we pay for mental health and addiction treatment. We pay for the diabetic to get their legs amputated. Forget any primary care. Forget glucose, monitoring. Forget primary, none of that. We just wait till it becomes a crisis. Well, of course, that is awful for the patient. And by the way, it's very costly for our medical system. So my point is what you all are doing at TRI is beginning to really tell people that no, this isn't make-believe. The same rules apply to chronic illnesses of mental illness and addiction as apply to other chronic illnesses. In other words, you're seeing this hand now all bandaged up. Here's a good case in point. I left Congress. I go to my new community, which is a Philadelphia suburb, by the way. So it's down in the Jersey Shore. But I know why I really got this award. It's because I got to move within a radius of TRI that, makes me okay for conversation. So anyway, I go down there. I go to my new doctor. I said, Doc, I'm in recovery from addiction and mental illness, and I'm an asthmatic. I take, cholesterol meds, so I guess I got cholesterol, blah, blah, blah. And if you look at my face, I probably need to get checked by the dermatologist periodically. He goes, okay. So he goes through, he starts going through his computer. He says, how many times do you wheeze? I said, well, a couple times a day I have to use my inhaler, I use about 4 times. 4 times a day? Well, wait a second, I see you've got this long-acting inhaler. Why aren't you using that? I said, well, it's just easier to carry my short. No, you got to use your short. He's looking at his computer, reading off his computer. Does it interfere with your sleep? I said, well, sometimes, especially if I use that fast-acting, because it gets me all hyped up. Oh, my God. It keeps going down. He's talking to me about my asthma for 15 minutes of my 20-minute physician's appointment. And so I'm on the way out, and I said, Doc, you know, when you checked out the rest of my blood pressure and height and weight and everything else, you saw that big scar down my back, you know. I've got reoccurring back pain, and if you wouldn't mind, if you could write me some Oxycontin, because, you know, when it gets to really break points of pain, it could really help me break that up. I found it's very useful. And he stopped for a second, he looked up, and he goes, didn't you tell me you were in recovery from addiction? I said, yeah. And you never even asked about it. I mean, come on. What is wrong with it? You even tell the doctor you're an addict in recovery, and they don't ask you one thing about it. How's your recovery going? What's going on? What are you doing to manage your recovery? This, that, and the other. So I, putting my kids, you know, ping pong table and everything else together for this last weekend, and of course the ping pong table fell, and my tip of my finger got pinched. I go to the ER. They said, oh, what are you allergic to? I said, well, penicillin and opiates. And the nurse was like, what? I'm like, what? And so, you know, I'm like, what's the pain? I said, there's other things you can give me, you know. And she goes, oh, okay. And so I'll check with the doctor. So the doctor comes in, gives me the Novocaine. On the way out, here's your packet, hands me a packet of, you know, how to tend to my wound, and with it is a script for Percocet that will last me 24 hours if I use it the way I used to use it. It's supposed to last me a week, you know. So I quickly, luckily my wife was in the room when he handed it and sort of had that sixth sense and grabbed it before I had a chance to stare too longingly at the Percocet script. So my point is that's where we're at in this country. We're at, like, there's like basic stuff we can do. It's not like heavy stuff that you can change the whole trajectory of the population health by doing some basic things. Like a checkup from the neck up. That's what I want. I want a checkup from, so if you're a kid, you know, the pediatrician asks for your ACE score. What's that? Acute childhood experience. Your parent, an addict, depressant, have a mental illness? Have they been locked up in prison? These are pretty easy questions to ascertain. If they are, you live in poverty, you know, you pretty much have a risk score that tells the doctor whether this is someone they ought to do the kind of long form screening for. I mean, you don't have to do the long form on everyone. Just find the high risk just like you would any other disease. That's why I come back to equality. Just treat it the same as every other. Now, the challenge we have, and I'll leave time for discussing this. I'm sorry I'm off on my tangent here. This is what you get when you get a former politician and you give him a room full of people who are listening to him. He'll just keep talking and talking. The point is that we can do better. And it's shocking that it's taken us this long to get about this. What do I think is going to change it all? I think our returning veterans are going to be the catalyst that changes all of this. So that no one's heard about this parity law, except, you know, now the insurance companies have to kind of put it together because of the federal law. But I think what's really going to drive the country socially, culturally around this is the experience of our veterans. Because this quote-unquote invisible wound is leaving them with astronomically high, 27 per day suicide rates for veterans, more dying at their own hands in the military than are killed in combat. We've got the biggest new cohort of veterans of any time in over 10 years because the military is downsizing dramatically as we speak. So the biggest cohort of people leaving the military right now, they're coming out. So there is a perfect storm, if you will. The law is coming into effect this July, and frankly, most health plans will come into effect in January. The question is, what's going to drive its real implementation? Because as all of you know, you can have something on the books, but whether it's actually implemented is a whole different thing. The challenge for us, and why TRI is such a critical partner in all of this, is we need to measure its implementation. So the way the law is written, inpatient, in-network, outpatient, in-network, inpatient, out-of-network, outpatient, out-of-network, pharmacy and ER benefits. If you cover those for the cardiovascular patient, for the cancer patient, for the diabetic, you got to cover them analogous, equally, to those with mental illness and substance use disorder. So obviously that's what the law says. What does it actually mean? That's where we need real good thinkers. We need people like Charles O'Brien looking at this closely, saying, this is not a proper analog to compare, addiction with this form of reimbursement for medical. What would be a better analog is to use this, disease and this prototype of care for those with substance use disorders. That's where the rubber meets the road right now, my friends. So whether we're able to get care as the law provides equally will depend on how it's measured and how it's defined. And that, you've heard this other phrase, the devil is in the details. It's the details, my friends, that are going to determine whether your child is able to get the treatment they need for an eating disorder or for severe mental illness or for addiction, or they're not, because the insurance company either knows what is clinically, recognized standard of care. Because guess what? Insurance companies don't even use clinically recognized standards of care in many instances when covering these illnesses. And they wouldn't think of doing that on the physical side, my friends. Wouldn't think of it. But because there aren't any eyes on the prize, in other words, people like Arthur Evans who are like watching over them and who can measure what they're doing, no one's going to hold them accountable. So our job now is, now that we passed the law, our job now is to have transparency and public disclosure of the implementation of the law. So by simply asking Sebelius, by asking the HHS Secretary or Department of Labor Secretary who oversees ERISA plans for the information, which is already under law, you can get this disclosure. The problem is that we haven't even asked our own government for the right data. In other words, they're not going to ask insurance companies because the insurance companies have taken them to the dance. You know how that phrase goes? You dance with the one that brought you. Well, right now, the Obama administration is dancing with the one that's bringing them health care. It's the insurance companies. They can't step on their toes. They want to be invited back out on the dance floor. So what do we need to do? We need to make sure we push the administration so that they can say, oh my God, United, Blue Cross, Anthem, Cigna, Aetna, it's these people, it's these recovery folks, they're on our ass. They need to see this. We got to do it. In other words, if we're not telling them what we want, how do we expect them to do what we need for them to do? So we need to be specific about, we don't want to get the paper deluge, them just to tell us, give us all this stuff, and not know what to make of it. We need to know what we want to ask so we can compare. Finally, we need to break down these barriers that separate the decision-making here. So we got to deal with 42 CFR, which prohibits the exchange of information across mental health and addiction and the rest of medical care. That's from a bygone era. We can maintain and promote privacy without curtailing the efficacy of care, the connection of care. This is about connection. Connection in the community, connection in the brain, and it's also about the connection amongst the different providers and the insurance companies, all of whom have to learn how to connect with each other much more effectively if they're going to provide interconnected care for all of us and our family members who need this care. So my word for the day is connection. It's parity, it's equality. My final word for the day is connection. We need connection not only for our brains to work better amongst the different regions, we need connections for people and their communities, And then we need the kind of connection that's going to allow for all of this within the insurance and amongst the provider groups so that we're all working to try to make the patient's health and outcome the #1 objective. And if we measure outcomes, as you do here at TRI, it's irrefutable. You pay for this, you get this. And if you can show that to insurance companies and the government, guess what? They're going to say, hey, we like what we're getting when we pay for this as opposed to what we were paying for before. Because if you take that lump sum of money we waste on acute care and put it into the kind of primary and prevention that Tom McClellan has spent his life advocating for, we will have a different world. And that is what I want to do, is I want to enlist in Tom McClellan's army of getting this word out, taking what Maiken and all of you have done, and make sure people understand it, and make sure that this historic opportunity to implement parity does not go unaddressed. And so I thank you very much.
I think we're going to give you this award. Like I said.
All I'll say is, this is perfect award, because we've all seen Tom McClellan's slides, haven't you? The pyramid. Perfect. Thank you.
That was really stirring, and now we're going to have a question and answer with, led by Maiken Scott, and if our panelists could please come.
Good morning, everybody. Thank you for your words and your enlightenment this morning, Representative Kennedy. I'm thrilled to be here. My name again is Maiken Scott. I'm a reporter with WHYY and a host of our new health and science program, The Pulse. I have been reporting on mental health and working in the area of mental health since 1997, I guess, at this point. So it's been quite some time, and I've been hearing about parity all this time. The whole time I've been reporting on mental health, parity was there, but hearing about it was one thing, seeing it has been another. So we'll talk some more about that. I want to welcome our participants on the panel. I'm sure everybody here knows Dr. Arthur Evans. He's the Commissioner of Philadelphia's Department of Behavioral Health and Intellectual Disability Services. I'm going to see him later, actually, today at Philadelphia's first I Will Listen Day, which is a very exciting initiative where people make a pledge that they will listen to people who have mental health issues. So if you can make it to Love Park later on. Now I'm doing your job. I think it's a great event, so it will be at Love Park all afternoon. Next to him is Carol McDaid. She is the principal at Capital Decisions and the co-chair of the Parity Implementation Coalition. And then our other panelist is Paul Samuels. He is the director and president of the Legal Action Center. So thank you all for being here. We're going to hear from you in just a moment, but Representative Kennedy, I would like to start with you. As I said, as long as I've been reporting on mental health, I've heard about parity. The first Mental Health Parity Act was passed in 1996. Now another one came in 2008, obviously. Where are we with parity? It seems like these laws were passed, but then maybe nothing happened is saying too much, but little seems to have happened. So what has happened and what has not happened, if you could just summarize that?
Well, very quickly, obviously, passed in 2008. Of course, President Obama then was elected. He obviously took this whole issue of health care reform and pushed that. That became kind of the overriding objective, and then implementing that, fighting off the court challenges, trying to get that implemented. So parity, like most times in life, just gets shunted to the side. I mean, that's the reoccurring issue here. It's treated separately. But the good news with healthcare reform is that healthcare reform really did help us take parity to scale. It really helped embed parity. Thank God we passed parity in 2008, because if it had been on the negotiating table when health care reform was negotiated in 2010, I don't know how long that would have lasted. But it wouldn't have lasted very long with the way everything was getting dropped at the very end in order to get this thing to pass. You all recall those days, right? Public optional drop. So finally last November we got the final rule, but July, some health plans will be have to take it up, and then in January all health plans will then be required. But as I said, we don't have the mechanism for evaluating implementation. So just as the same status quo now of trying to appeal a denial, it's still happening. And in addition to that, there's just really no opportunity to gauge how long it takes you to get an appointment if you need care, or whether the services that you need for your brain illness are going to be comparable as any other medical services that you would need. So the real issue is here, we don't have the culture of parity. We have the law, but we don't have it practically speaking. And so the job of all of you and TRI is to really help us make that transparent, so hopefully with the light of day on it, people will be forced to fix this broken system, because systems like this don't change overnight. Because what will require it to change is different funding streams going to different, care models. Well, that means you're going to have to take money away from this person and give it to this person. Well, that's politically not an easy thing to do. So we need to build the political argument that, first of all, it saves dollars, both on the medical spend and the behavioral health spend, and it makes for a better country overall. We know those dollars now. This isn't soft science. With modern analytics tools, and I know you've partnered up with some health analytics folks, you can really measure the outcomes. So this isn't just because I'm a bleeding heart liberal and I believe in, supportive housing and supportive employment, and God, Patrick, not again, we're supportive this, and aren't you liberal? You just love all these supportive Well, no, this isn't soft. This is going to get you people not getting readmitted to the ER, people reducing their medical spend, not having, as Charles O'Brien says, as many liver transplants, not having as many broken bones, not spending as much time with contusions, lacerations in the ER. You can measure all the reductions in morbidity by employing these supportive systems of care. But the problem is they're non-medical. Many of them are non-medical. So the challenge is, will medical system reimburse for them? If they can show that it reduces medical costs, and by the way, incarceration and law enforcement costs, I think you've got a very compelling opportunity right now with where the country is with its budgetary challenges. Because you can make this case not on the humanitarian side, you can make it on the economic side very compellingly. And by the way, you add the notion that veterans deserve no less than an urgency of effort. And I think you've got a dynamic message that can win on all levels on a bipartisan basis.
Thank you. Let me go along with our panelists. I wanted to ask each of you to quickly describe how the issue of parity affects what you do. I mean, do tell us what you do in a thumbnail sketch, and say how parity affects what you do. Dr. Evans, do you want to start?
Sure. In Philadelphia, I think talking about this issue, we really have to think about the private sector and the public sector, because those are two very different systems. They're financed differently, and they're different issues. And so I think Patrick really covered well the issues around the private system. The private system, and I like the analogy of the civil rights movement. When the civil rights legislation was passed, that was really the beginning of a new era. So people had to advocate and to use those laws in order to get the rights. Just passing the law was not enough, and I think the same thing applies in this particular case. And so I think in the private sector, we still have a lot of work to do to really get parity, and frankly, I think that we have more policy decisions that we have to make in order to make it. I don't know that parity alone will get us everything that we want in terms of equity, in terms of how we finance our service system. On the public side, the big issue, the big elephant in the room are people who are uninsured. And right now, we have literally tens of thousands, hundreds of thousands of people who in this state who are uninsured. Their behavioral health services are covered primarily through state grants. The first cuts that come to people or to agencies like mine are to those state grants. And so it's really imperative for us to understand Medicaid expansion, why it's so important, because once those people are covered through Medicaid, then they have the access to the parity legislation. As long as those people remain outside and uninsured, you have lots of people that have compromised access to care. So I think it's really important to make that distinction. And if you're talking about people who are addicted, lots of them are uninsured. And so we really have to address that issue. I also think that in terms of the state of Pennsylvania, Pennsylvania actually has a really good Medicaid system. So people who are in the state's Health Choices program get really good access to care, primarily because it's the local county governments that are managing those resources. And so the financial incentives or the disincentives for admitting people to care and keeping people in care are not there in the ways that you would see in a completely privatized system. And so, for example, if you look at people with serious mental illness in Pennsylvania, or at least in Philadelphia, University of Pennsylvania did a study to look at the health outcomes of people who have serious mental illness, and they looked at a variety of HEDIS measures, other kinds of standardized measures, and they compared their health outcomes to people who didn't have serious mental illness or who were not receiving treatment. People who had serious mental illness who were receiving treatment actually had better health outcomes than people who had similar conditions who were not connected to the behavioral health system. So what that means is that in Pennsylvania, the state has done a really good job of constructing a healthcare system that works really well, and I think the way it's been implemented, certainly in Philadelphia and other counties, people have not only good access to behavioral health care services, but they're also getting access to health care services.
Just to add to Arthur's point, we need an NAACP for the mental health movement. We need lawyers, and we need lawyers to be able to take these cases in class action form to start and you know, even petition the government. You know, there's right of action is limited, but still, nonetheless, there is the power of public perception here. And we need to take the data that Tom and all of you have come up with here and bring it to public light. And if you need to, you know, sue for disclosure because of using litigation, we need to do that. And that's why this is in like to that civil rights, because you got civil rights, then you needed voting rights and fair housing, fair employment. You know, we've got the same trajectory in parity. We got the parity law, but we need to take those next steps to fully realize the notion of parity, which is that broader system of care that you're talking about.
Yeah.
Carol, let me move on to you. Tell us a bit about what you do and why parity matters.
Sure. So I'm a federal advocate in Washington, D.C., and I worked for 12 years with Patrick and with his dad and other supporters on getting parity passed, and I've spent the last 6 years on trying to get it fully implemented and enforced. And Patrick's right, we're nowhere near where we want to be. And I work with a coalition of addiction and mental health consumer and provider organizations. And with their support, we're working on really 3 primary things to try to get this implementation and enforcement done. The first one is we are working on getting a toolkit on how to actually apply parity and have employers and states to learn how they should implement it. And it's being developed by a benefits consulting firm. And with Patrick's help and the Kennedy Forum and Jim Ramstad, we're going to be convening a panel of state experts, managed care executives, state former insurance commissioners to help us take what's the guidance that's put together for employers and convert it into something that's highly useful for states. Because I think part of the slowdown of full parity implementation that most people don't realize is that the primary enforcement of parity happens at states, not at the federal level. And while the federal agencies do have some secondary authority over a state that's not implementing it properly, the primary work now on parity is in the states, places like Pennsylvania, kind of making sure the rubber is hitting the road at the right places, that guidance is being issued to people who are selling insurance in your state. And the second thing that our coalition is working on is making sure that a Medicaid parity rule gets implemented by the end of this year or as soon as possible. Because really, if you think about it, it's totally counterintuitive for the subset of patients that have the highest prevalence of these conditions and the lowest capacity to pay for it not to deserve addiction and mental health benefits at parity. It makes no sense, and so we're continuing that fight. And the last thing we're doing is we have a toolkit and a website that we maintain, and the website is parityispersonal.org. We're updating the toolkit that you can, both consumers and providers can use to learn how to do an appeal yourself. Because Patrick's right, it's very labor intensive to do this on an appeal by appeal basis, but we do want to empower consumers so that they can learn how, if they have an improper denial of care, how they do run it, exhaust their internal appeals, and then take it to external appeals. So we're helping people do that.
Paul?
But let me just add on that. The whole internal appeals program is problematic because just like the banks used to hire like their consulting firms to tell them they were doing all right with all their toxic investments and they said, of course, you're paying us. We'll tell you what you want to hear. That's the process now that's regulating whether your child gets benefits or not. So in addition to working the outside game of appealing, we also need to have a strategy to actually change this so that there are some, conflicts of interest or whatever statutes that apply in this case, because this system is rigged, and it's not rigged in the right way right now.
Good morning. At Legal Action Center for 41 years, our mission is to advocate on behalf of people who are suffering from or in recovery from addiction, as well as HIV, or people with criminal histories. And the two main things we've focused on in the addiction and mental health area are to try to expand the number of people who receive the care they need, as well as prevention, and also to fight discrimination. And parity has always been a key component because parity affects both. Lack of parity is discrimination, as Patrick talked about so eloquently. And lack of parity has also been a huge barrier to people getting the care they need. And we start with the reality that today the numbers are just about the same, sadly, as they were when I started working in this business a few years ago. Which is, we look at, there are 23 million Americans who have alcohol and drug problems, and barely 10% get the specialized care they need, and that number has not budged. And similarly, there's over 40 million people with mental health issues, and barely half get the care they need. And what's been the major reason why people don't get care? Well, they can't afford it, and the care's not there. And really, I've been in the trenches now with Carol and Tom and others for a long time. And really what we've seen is until parity and the Affordable Care Act, what was our funding base? It was essentially built on the model of getting the best tin cup you could find and come up with the best marketing tools to beg. Because we had to go to federal appropriators in Congress and state appropriators in every state and say, please give us money for this. That happens to be one of the major health problems in the country. And, as Pat said, affects not just on health, but on crime and just about every social welfare problem you can get. But we're not included for the most part in Medicaid, which is the major public funding stream. And we're not included for the most part, or very poorly included, in private insurance, which is the major funding stream for healthcare in America. Those two together are what fund healthcare in America. So we're having to beg. And then we're trying to build a bigger system basically on twigs and leaves that can be blown away at the slightest political wind if it blows in the wrong direction, or economic winds when the economy goes down. And then I would say also, when I started in this field, the major metaphor for advocacy that people told me about is that we're really good at a circular firing squad, meaning our approach is let's form a circle and shoot in. And we owe a huge debt of gratitude to Patrick and to Carol and to other leaders that we're much past that now. We've come together in our advocacy over Parity, over the ACA. Carol was instrumental in forming the Parity Implementation Coalition and the Parity Coalition before that to get Parity. We also formed a coalition called the Coalition for Whole Health. And we now have the addiction and mental health fields working closely together. But we have a long way to go because, as Patrick talked about, a law is a promise. A law is not reality until we figure out how to keep the promise. And that's where we are now. I congratulate Patrick on his extremely well-deserved honor today and thank TRI for giving that, because when you talked about your family legacy and your father of expanding circle of opportunity for all Americans, there's no better description I think I've ever heard than what Parity can do. But that's what we have to make it do.
That's right.
And now we've got real challenges at every level, as everybody's talked about how do we implement this. And a big part of it has to be advocacy. It has to be advocacy at the federal level and in every state capital, and also, as Patrick has talked about, it has to be advocacy in the courts.
Yeah. Paul, let me ask you a follow-up question, and we will get to these questions in a moment, so keep sending them our way. Paul, let me ask you, Parity on many levels appears to make sense looking in from the outside. It seems to eventually reduce costs. It's a common sense approach. So why have insurance companies been so reluctant to
Well, I mean, I think there are a number of
this?
reasons that come together, but one of them is the bottom line. Often starts there, and some of that, frankly, through the years has been for understandable reasons, meaning, we met with lots of insurers, and I know others have as well, and we would make the cost-saving arguments as well in healthcare as well as in other fields, and they would say to us, well, cost savings in criminal justice and social welfare and in welfare and child neglect and all that, that's all fine and dandy, but that doesn't save us any money. And then when it comes to savings in healthcare, we're going to be making the investment, and then by the time that the cost savings come, the individual's not necessarily going to be insured by us. So now there are certainly counter arguments to that, but we have to realize that we're dealing with real hard, dollars and cents issues. So the points that Tom and Patrick have made about we need the data. We need transparency, and yes, we need to fight for transparency, but we need the data, and then we need to make the strong case that we can make to demonstrate to the insurers why there actually is a financial benefit. And at the same time, though, this is now the law, and we've got to enforce it, and everybody has to obey it, whether they like it or not. And I think that becomes a huge challenge for us. How do we mobilize in all of those spheres to win over with good arguments the insurers when they see the benefit for them, but also to enforce the law regardless of how that falls?
Paul made a really good point. That's follow the money. So if you're not including all the budgets as it relates to the costs of mental health, you're not going to be able to demonstrate the savings of mental health. So, for example, with those who are incarcerated, and Miami-Dade, I was just down with Judge Leifman, he's managed to get the state of Florida and the county to give him the budgetary authority for all these areas that don't come under mental health but are all mental health related. And he's made a bargain with them. I'll save you on all these other budgets if you give me the money to do it. He's done it, and he's reduced the recidivism for the severely mentally ill in the Miami-Dade County Jail from over 70% to down to 35%. And with those savings, he's now able to continue to expand this model. I just talked to Rahm Emanuel. He wants to do it in Chicago with Tom Dart at the Cook County Jail. I was out in Los Angeles. They want to do it because LA County's they're building another mental health psych unit within the prisons, as opposed to spending that money to reduce the recidivism and keep people out. But like Paul said, this isn't just about suing and doing the legal stuff. It's about Wharton and getting your economics and business folks to help come up with the paradigm for the business case. Because if you get the business, then this becomes easier for us to do. We don't have to force it.
Carol, we have a question for you from the audience. What funds have been appropriated or allocated for enforcement of parity?
Well, there was a provision in the law that allows there to be imposed a civil penalty of $100 per member per violation. But if you look at the history of enforcement actions in healthcare, whether it's the HIPAA law, in general, the feds are not heavy enforcers of healthcare laws, and I don't expect, unfortunately, that they will be on parity unless we really mobilize and make it a huge case. So in general, I think there have been dollars appropriated for the Department of Labor. They do have people who go out and investigate if people are claiming that an employer plan that they govern is running afoul of the parity law. They do have some investigators. There have been, maybe $10 million appropriated for those investigators, their training and going out in the field and going out in the regional offices. But in general, there's been a limited amount of enforcement authority, and unfortunately, the authority that feds do have oftentimes goes unused.
And Carol, do you think consumers are even aware of their rights? Are they aware that there is a parity law? And secondly, do people know where to turn? So if somebody has a child who has addiction and they're in the throes of trying to get them treatment and they're getting denied, do they have any clue who might be able to help them, like who you are and where you are?
Yeah, and actually that's why I gave out that website, because we are one place for help. TRI's got a great website, as do others, about if you're a parent and you've got a kid with addiction, where to go. Then they have a consumer guide for what you should expect if you send a kid to treatment, what a good treatment center looks like. But in general, the American Psychological Association just did a survey, and less than 10% of Americans even know that there's a parity law according to that survey. So there's very little information out there, and I think Patrick put his finger on some of it. Right when this law was going into effect, all of the administration's resources were focusing on the Affordable Care Act and getting that up and running. And so there weren't commercials like you see about, hey, you've got new rights and benefits if you or a loved one has an addiction or mental health problem. So I think Americans don't know about it, and frankly, we're doing forums like these so they begin to know more about it. And we do want to be a resource to help teach people, if they think there's been an improper denial, how to deal with your internal appeals and external, and refer you to lawyers when you need it. So again, please use parityispersonal.org as a resource there.
Dr. Evans, a question for you from the audience. What is your department planning to do to monitor parity implementation in Philadelphia?
Yeah, well, that's not an area that we have any kind of authority over, so we don't have any ability to monitor to that. I think the issue, I think both Tom and Patrick said something that I thought was really interesting. I hope we don't lose, and then Patrick framed it around a culture of parity. And I think that is a really important idea and concept, because part of the parity is part of the issues around parity are going to be around the legal and around the financial. But we have a whole treatment system that has a certain culture, and that culture, I believe, doesn't give us the kind of parity and equity that we want. And I think there are a lot of things that we can do to change our treatment system so that it does foster more equity in terms of the kind of care that people get. I also think that one of the other concepts for parity is, for me, this idea that on the physical health side, we understand that we have to use public health strategies to help people. And we really don't do that on the behavioral health side. And Tom's analogy about diabetes, I think about if the behavioral health world were in charge when we had a flu outbreak, our response to that would be to build more hospitals. Because that's the way we think. We only think in terms of treatment, and we don't think about upstream activities or upstream strategies. We don't think about population health strategies. We don't think about differentiating our approaches. For example, thinking about policy issues. In Philadelphia, for example, or in Pennsylvania, there was, in the city, there was an opportunity for liquor stores to be more easily sited within the city. Now, we know without any question that when a liquor store is placed in a community, it creates all kinds of issues related to substance use. Now, our approach can be to wait till the liquor store is there, for people to develop addictions, for all of the behavioral health issues to emerge out of that. Or we can think about, okay, how do we affect policy and advocate at that level before those kinds of things are done? We don't do enough of those kinds of things. So I think this issue around the culture of parity and equity, I think we need to think more about that and think about strategies that we can be employing so that we have a more efficient way of addressing behavioral health issues.
So to bring a little optimism and hope to the table, how do you see services evolving and changing with this whole concept of parity in place? Give us some good examples.
Well, I think one area is in the area of behavioral health and physical health integration. There's a lot of good work is happening in that area. You have physical health providers, primary care providers who are integrating behavioral health specialists within those settings. Vice versa, you have mental health and addictions providers who are embedding primary care within those settings. And in Philadelphia, what we're trying to do is create a real continuum, because the reality is for people who have very serious mental illnesses, for example, their primary care provider is going to be on the behavioral health side. It's not going to be on the physical health side. So the issue there is how do we make sure that the behavioral health providers really have good connections to primary care. So that's one way that I think that we're seeing care evolve because of parity and sort of the notions that it brings.
Paul, question for you from the audience. What is the status and probable impact of current lawsuits that are driven by parity or disparity of care?
Sure. Well, yeah, I'm one of those lawyers. So, and I'm happy to be. So, I mean, I think, I think there's a huge opportunity here to accomplish actually the goal of the last question as we focus on litigation as well as policy advocacy, and that is what the goal of being able to make sure that people get the care they need, the type of care they need, is really critical. When we have approached the implementation of parity, our biggest concerns have always been not so much about will people be able to get coverage for an outpatient visit, because that's a lot like going to the doctor, or if you have a real crisis and you're hospitalized, because that's a lot like having a crisis in any other disease, but what happens with everything else in the middle? What about medications? What about being able to get whatever medication you need? We know there's a lot of discrimination out there against people's ability to get medication-assisted treatment for addiction, and also, difficulties for people getting the medications they need for mental health issues. What about, since as we've talked about, addiction and mental health are often dealt with as acute episodes rather than the chronic diseases that they are. So what about the kind of care coordination, case management, those kinds of services that are available for other chronic diseases? Will they be available here? What about recovery supports in the same notion? And also, what about intermediate services, as the parity regulations call them? What about residential treatment, intensive outpatient? And fortunately, the regulations, when they were finalized on the commercial insurance side, cover all those kinds of situations. So we now really have an opportunity to try to make this all happen. And there have been some suits that have been filed. There's not a lot of results yet. But one thing I did want to take a minute and share, both because it's a very encouraging development in a lot of different directions and can set an important precedent in terms of what we need out of litigation, but also in terms of maybe how to try to accomplish this. And that's that in addition to the possibility of private lawsuits, we've also been focusing a lot on trying to get state governments involved. They've got a lot more power. A private litigant is going to have difficulty even finding out exactly what is going on. If you sue an insurance company, what exactly are their policies on medical necessity for addiction, for mental health, but also for other illnesses, because you have to be able to compare them. We know that kind of transparency is hard to find, and that's a major goal of our work. But state enforcement agencies have the power. They have subpoena power, and they also have the political clout to really get much deeper into what's going on. And one of the major opportunities there is with the attorney generals in every state, as most of them, if not all of them, have jurisdiction here. And the New York State Attorney General just won a settlement about a month ago against an insurance company and the behavioral health company that it had hired in upstate New York. And the focus was on residential care. And let me just, if you don't mind, just give me a minute to, I'll rattle off some of what the Attorney General found, because this demonstrates both what are the problems out there, but also the value of being able to get in there with an investigation and find out what the numbers and details really are, and then use that to enforce the law. So the New York Attorney General found that the insurer was applying utilization review more rigorously and more frequently for behavioral health than for medical surgical. Now, we've always felt that, but listen to the numbers that they were able to get. So what they found is that while behavioral health benefits comprised less than 3% of all benefits paid, they comprised 14% of all the utilization reviews, so way out of proportion. And the insurance company denied 21% of the behavioral health reviews as compared to only 15% in medical surgical. When it came to residential treatment, the insurance company denied 47% of the residential claims compared to 18% for medical and surgical, comparing it to skilled nursing primarily as the comparison. So 2.5 times more denials, almost half the people who sought residential care were denied it. And then there were also the way that they did denial letters, they weren't revealing exactly what had happened, so people really couldn't appeal. And in fact, they were also classifying denials based on lack of authorization or clinical standards as not being medical criteria, so medical necessity criteria, so they weren't allowing people to appeal. So less than 3% of people appealed, but when people appealed, 40% of the appeals were upheld. So what this demonstrates, I think, is what the problems are, but that there are solutions. Getting in there and getting the data will be extremely helpful, and the law has teeth when you do it.
And let me add one more point to this. If veterans, most veterans, well over half, are going to be getting their care through their private employer-sponsored health plan, not the VA. Even if they are lucky enough to get in the VA, they have their own challenges getting care there. But the point is that CEOs in America couldn't care less about somebody with an addiction or mental illness. We're just not too very high on the political level of worry for them. But if one of their employees is a 2 or 3 tour of duty, Iraq or Afghan war vet, they're trying to get care for their post-traumatic stress or TBI, and this happens to them. You're going to have a front-page New York Times story about it. You're going to be able to go, those CEOs are going to start cracking the whip on their third-party administrators to get with the program, because this is more of devastating economically to them, is the bad reputation they're going to get in the marketplace as places of employment that don't care about our nation's heroes. And we show up with Iraq, Afghan war veterans and point this out, you're going to see a sea change happen quickly. But all of this has got to come together at the same time in terms of these cases having the integrity and legitimacy, and then you overlay the messaging and the politics, and then I think we're going to have the changes that we need. This is ultimately a political issue. You need the power players, both who appropriate and who regulate, to care about this. Because otherwise, you can't see the forest from the trees. We're all going to be fighting over the tree here, tree there, as opposed to, are we really getting what we need overall? Is that culture of parity in place?
Yeah, and if I could just add this, to second that emotion, is that making noise makes a difference, because this is a political battle. And even in the legal sphere, making noise to attorneys general or to state insurance commissioners, to governors, makes a difference. And I can tell you also in New York, when we asked the Attorney General, so what really got you rolling on this? They said, well, we got lots of calls on our consumer hotline complaining about people not being able to get residential care. So, and making a phone call to a hotline is a lot easier and a lot cheaper than filing a lawsuit.
Mm-hmm. And to ask a general question, is the issue of stigma still the main barrier? It seems like we've been talking about this issue for so many years, and still, you said, Representative, earlier, we're at ground zero. You said, Paul, that the numbers haven't budged despite so much work, and I guess the only reason I can think of is that people aren't talking about it, yet you said, Representative Kennedy, that this is all of us, this affects all of us, this is not a niche issue. So is stigma still the main barrier for getting people to talk, for getting that political will going? Maybe all of you can weigh in on that and think of some solutions.
I love what you guys are doing here in Philly. I mean, the rallies for recovery, the standing up, the faces and voices, let's be counted, trying to not be shamed by these illnesses. You show up at these rallies, it's incredible, the sea change in consumer advocacy. I think that's going to lead to a lot. Just to follow with Paul's, in Rhode Island, my insurance commissioner told me the only people who call me are providers. So I'm not getting consumers. So it's hard for me as an insurance commissioner to do what the Attorney General did in New York, because they want to move because it's a consumer issue. They don't want to move because it's a proprietary issue, someone didn't get paid. It just doesn't have the same political, force that a real consumer right. So this is going to have to rely on a lot of consumer participation. And
Dr. Evans, any thoughts on
stigma? I think this is a huge issue, and just for some context, I've spent most of my career trying to figure out how to make treatment better. My department spends literally millions of dollars each year trying to improve treatment, get evidence-based practices, trauma-informed care. I can go on and on. But the more work that I do in that area, the more convinced I am that we also have to deal with the issue of the stigma associated with behavioral health conditions. Because we could build the best treatment programs in the world. If people don't want to come, it's not going to matter, and that is a huge issue. So, Paul mentioned the 90% of the people who are addicted in this city, around the country, who don't come into treatment. 80% of those people don't believe they need treatment and don't want to come to treatment. Even if we built all the treatment programs that we could, it's not going to deal with the issue. You mentioned the I Will Listen Day, which we're doing actually around the city. We have sites around the city. It's a campaign that's starting here in Philadelphia by NAMI. And the whole idea is to try to reduce stigma around mental health issues, to get people to talk about them. And I think that we have to do more of that. Patrick mentioned the recovery walk here in Philadelphia. The first recovery walk in Philadelphia had about 150 people. Last year we had 18,000 people. It's the largest recovery walk in the country. And we've seen the power of the recovery community being mobilized and putting a face on recovery. And I know Carol's work very important in that area as well. So I think that putting a positive face on recovery, 30, 40 years ago, people whispered, cancer, and now you have tens of thousands of people do marches all over the country. We want, and I think we need the same kind of energy and culture and sea change for behavioral health. We saw that it made a difference in terms of breast cancer and other kinds of diseases. I think it can make a difference. I think it does make a difference when you have 20,000 people in Philadelphia walking in the streets saying recovery is possible. I think that can't help but change public perception and reduce the stigma, make it more likely for people to reach out for help, and make it more likely for those of us who may not be addicted or may not have a mental illness to reach out and to help people.
And Congressman Kennedy, if I may ask, you are very open about your own recovery. You joke about it. You make it something people could talk about at a cocktail party or at an event like this. So how has that been for you? What have been the positive effects of that, and what have been some drawbacks
Well,
of doing
first,
that?
I never was some big courageous person who decided to talk about my challenges. I got myself splashed all over the newspaper, arrested, pretty much my disease followed me everywhere. I got arrested in airports, on the high seas, by the Coast Guard, and regular traffic cops would arrest me. So, I didn't have, and I couldn't understand I had a problem. It's like going back to Arthur's. The biggest challenge if you're in a mental illness or addiction is your ability to discern that you are. And your inability to really see it's as bad as it is. Everyone around you kind of like tiptoes and knows it's bad. You can't really pick up the cues. So that is a challenge. But as Tom always talks about, we're not doing sensitizing people early on that they need to be aware and do that early primary. How many drinks are you having? Are you taking your meds as prescribed? Do you come from a family history of alcoholism or addiction? Does a family member have, they ask this for cancer, in order to find out whether they need to do an extra little check on cancer. Is there a family history? They don't ask on it here. We could do such a good job at preparing people to not feel offended. God forbid your doctor said, do you think you might have a problem? Oh, of course not. Because if you start early and it's kind of natural as part of healthcare, then it's not stigmatized. Mm-hmm. So, anyway, I just pointed, a great story I had was the Green Berets have more mental health per capita than any other branch of the military. And I said, well, why do the Green Berets need mental health? They jump out of planes, they swim under the water for 5 miles without breathing. They come out on the beach and they speak 5 languages, and then they, take out, Osama bin Laden, and they go home and they read to their kids. I mean, these people don't need mental health. And the commander at the Fort Bragg, John F. Kennedy Special Warfare School said, no, Congressman, you got it all wrong. We don't look at mental health as something for weak people. We look at it for strong people to make them stronger. And I'm like, wow. And he said, you know what we call it? We call it force multiplier. And I'm like, damn. I said, you give a little bit of that force multiplier to everyone else, they're going to want some of that force multiplier, because we are Americans. We want to be better and more powerful and more beautiful and richer and smarter. I mean, we want more. We're Americans. Why not phrase mental health as something that's going to make you healthier and happier and more productive? And I mean, that is the way. So instead of feeling, oh my God, I'm a loser, I fell down, I got, shamed, that's the way we try to, you can talk about it, Patrick, it's all right, you can talk about it.
But what helped you think of your recovery that way? Or do you think of it that way?
Well,
or do you still sometimes
no,
feel
I love it. I feel blessed, at people who are in recovery after having been through the travails of dealing with addiction. Blessed because there's a realization, now I know there's another solution in life, and I don't have to battle this kind of in an arbitrary world, all disconnected and not knowing where I'm going. So and I think teaching coping mechanisms, and my cousin Tim Shriver runs Special Olympics, runs this social emotional learning out in Chicago for trauma and kids who've affected by trauma. Their scores have gotten so much better on all their tests because they've dealt with their effective trauma. So schools, my wife's a school teacher, the fact that they don't know about social emotional learning is going to be a challenge for us, because the kids, as my wife tells me, can't learn what they're being taught in classroom if their kids are coming from homes where they're traumatized. So I think that there's a much broader discussion that needs to take place on this.
Let me get to another question from the audience for, I guess, Patrick, and for anybody else who wants to answer it. What about parity of research funding for mental health and substance abuse?
Well, so again, back to the Kennedy thing, because it works for me so far. I asked my cousin Caroline to give me her father's presidential library for the anniversary of the moonshot speech that President Kennedy said that, before the decade is out, we'll put a man on the moon, return. So that galvanized a whole scientific effort, because we said we were going to climb the wall and get to the other side. And frankly, the supercomputer tools that we developed at NASA actually give us the analytic tools today to go to inner space, not outer space. And literally, just politics-wise, telling neuroscientists that they're the astronauts of today, that the discoveries that they make in neuroscience, understanding this complex organ of our brain, is the most important research we could do as a nation, because it's unlocking people from being imprisoned by their mental illnesses and their traumatic brain injuries and everything else. So, and I guess the catalyst in likening this to the moonshot, the Sputnik for this race to inner space, is the veteran suicide rate and the veteran post-traumatic stress. This, quote, invisible wound of war, I think is the catalyst for us to really ramp up what we're doing on neuroscience.
One thing that I would add to that is, it's not only more behavioral health research, but I think it's the kind of research. I think that we have to have a greater balance between the biological and the social and the environmental. One of my big pet peeves right now is that we know without a doubt that one of the best predictors of people's physical health and their mental health is where they live. And you look at where people live, that is a great predictor of what people's health outcomes are going to be. Yet, if you look at how much research we do on trying to understand social environments, trying to understand physical environments and their impact on issues like behavioral health, it's minuscule. And I think, I am absolutely for the neuroscientific advances. But if we also know that there are these other things that impact on people's health status, we ought to be looking at those things and have a much more balanced approach to our science.
Mm-hmm. Question from the audience for, I think, Carol and Paul, probably. How can we educate providers on parity so they receive uniform information and are able to identify violations?
Well, I think one way that is happening is using the provider trade associations, both at the national and state level, to educate people, and also to make sure that they know that the people that they have contracts with also need to be held accountable. Because once you educate the providers, they then start demanding reimbursement, which is a part of parity, and coverage for their patients at fair rates. So that's pretty much, I think, the driving force for educating providers at the moment.
Mm-hmm.
Yeah, I totally agree with that, and I think it also has the potential benefit, as we were talking about earlier, of as Carol was just saying, to educate the patients as well, because then when, as Patrick was saying, when consumers complain, people listen. Mm-hmm. When providers complain, they listen somewhat. But it's a whole different conversation, and I think that probably one of the best conduits we have to educate consumers is through the treatment providers, but there are also other ways that we need to work on educating the folks in our field who are affected by these illnesses, including trying to get better education to parents, into schools and communities. We're not doing enough prevention work, and we're also not doing enough education work for family members about their loved ones who are having problems.
What is the role of providers? Are they currently doing things to help consumers get the care that they need? Is that a role they should or could even have, Carol?
Yeah, I think they are, and I think the more impaired the patient as a result of their mental health or addiction problem, the more you'll see good providers getting involved in helping them advocate for payment, doing the appeals if necessary, and working with them. I also wanted to underscore, I think Paul said something about making sure we educate families, and I cannot underscore that enough. I do a lot of talks, and we convene panels and forums on parity in the states. And more frequently, it's the families who are advocating for the patients than the patient themselves. So having them really armed, and they also are naturally very curious because, quite frankly, in a discriminatory system, they're picking up the bills and paying the freight. So they're highly motivated to understand this law. And so as you think about strategies at the ground level for educating people, having family seminars, even though it's challenging to get the complexity down to the bite-size, talking points for them, they're hungry and they're ready and they're interested in getting this information.
And if I could just add too, I think they're also, that's our best opportunity to try to reverse the ignorance and prejudice and discrimination and lack of understanding that's out there, is to educate the people who are most affected. And that's not just the individual with the illness, it is their family members. And I think, I think we're close to that cliched point of a tipping point, where I think on the one hand, we're benefiting a lot right now from the fact that the public understands that a lot of what we've been doing doesn't work. Whether you want to call it the war on drugs or, certainly the amount of incarceration and arresting of people who have addiction and or mental health issues, and the percentage of people who are incarcerated who have addiction and or mental illness is enormous. It's a large percentage of the people who are incarcerated have at least one of these illnesses. So I think the public right now gets that that's not working. But what I don't think we've yet successfully made the case for is what's the right alternative. What will work, what needs to be done. This is our chance, and shame on us if we don't seize it, but what a huge opportunity we've got to really make a difference now.
I have a question here that says Tom on it, so I don't know if you want to come up here or if you want to pass it on to somebody else, but how can we promote training for physicians, psychologists, and so on with substance abuse? And secondly, what is the future of residential treatment for addiction? Or
Probably not the right person to answer, but I will nonetheless.
Well, if you want to pass it on.
I will launch into it. I'm happy to say that with help from the Betty Ford Institute and the SCAFE Foundation, this July we will be offering the first nationally available course for physicians. It's designed for second-year medical students. We did a survey. There was of 164 medical schools, 7 had a course in anything having to do with addiction or substance use disorders. So through the recognized provider of online courses, that's now going to be available in 138 medical schools starting in July. So that's a good thing. It's not as good as the full year course that Dr. O'Brien developed here at Penn, but it's way better than nothing. What's the future of residential care? I think it's part of the continuum of care. It is, in my view, and I think the research backs it up, a damn good start. You need to stabilize and to biologically manage a person to the point where they can begin to participate themselves in what is going to be ultimately self-managed recovery. But the failure to follow through from residential, a 30-day, a 6-week residential care with something that's much, that complements it and sustains it is a major failing.
Sure. Do we have a moment to have Dr. O'Brien weigh in?
Charlie, you should say something on this.
Yeah. You can, I don't know if this one moves. Maybe take one of these.
Actually, it's a totally different level of disparity that we haven't really addressed, because we've been talking about disparity of services, healthcare delivery. And that's bad enough, because we do have some good treatments, but our treatments could be a lot better. If you compare what we know about heart disease, for example, we know so much more. I mean, heart disease is simple compared to addiction. The brain is so much more complicated. And of all the brain diseases, the disease that we know the most about, and think about this because you may not have heard this before, the disease that we know the most about is addiction. We know a lot about addiction. We know where it starts. We know the parts of the brain involved. We know a lot about the actual mechanisms of addiction. It's far more than we know about schizophrenia, depression, anxiety, any of the so-called traditional, mental disorders. And there's a great disparity, because if you look around at the major drug companies, who, we all say this is a capitalistic society. If, the private can do it much better than the NIH can, they say anyway. But the fact is that there's almost zero research in the drug industry on addiction, and there's a lot on the other mental disorders. That's a disparity. So the Institute of Medicine, the IOM in Washington, did a study, and I was on the committee that actually tried to figure this out, and we agreed that there should be a lot more research on addiction, and probably would develop a lot new drugs, and it would be a stigma, for example, would probably be lessened if we knew more about what makes someone keep relapsing, even though you spend $20,000 a month on a residential program, and then they get right out and they relapse again. Why is that? But we would know more, and we would develop better drugs. And so we brought in a lot of CEOs from various big drug companies into our committee in Washington, and we asked them, why aren't you studying addiction? And the answer was 100% of them said, it's because we have an obligation to our stockholders to try to make money, and there's hardly any money in addiction, and therefore we're not studying it. We don't think if we develop, there are a few good drugs, and it's not as though we have nothing, but compared to what we could have, it's nothing. And so we wrote that up, and it didn't do any good. I mean, we also tried to figure out ways that we could financially induce them to work on addiction. It didn't have much impact, but this relates to what you all have been talking about, because if we could convince them that you actually could get paid, so if you developed a better medication for cocaine addiction, for example, you could make money on that. There would be a good reason for it. I think that the treatment of alcoholism and opiate addiction is starting to make money as more people are covered by insurance. But I think that parity of services and parity of research, could go together. One could augment the other, and I just wanted to point that out because it's another area of impact.
Mm-hmm. Thank you so much. We're going to have to slowly wrap things up. So I wanted to ask each of you to give us some homework, so to speak, to give us something to do, or to talk about things that we can all do, but maybe think of some small and practical examples of what individuals can do to promote parity, to ask for the services that you've all described, to help families who are affected by addiction and who may just be very overwhelmed at the moment to do all this struggling that we've been asking them to do on their own. So what can each person do? Some ideas. Who wants to start?
Well, I'm an advocate, so I would say what each person can do is make noise. Mm-hmm. And make noise in the way that's most comfortable for you and in the setting that's most comfortable for you. So for some people that can mean, going to the state capitals, getting in touch with your members of Congress, and governors and all, and saying, look, we have these really important laws, the Affordable Care Act and the Parity Law together now for the first time in our nation's history, requires that most people need to have coverage for addiction and mental health in ways they didn't before. But that's got to be enforced. Make it happen. But then there's also what people can do on the individual level. Make sure that your insurance policy, if you're insured, that you know what's in there for addiction and mental health. I can tell you, one of the problems we're having is just trying to figure out what in the world's in the plans. And how do you compare that to the other coverage for other illnesses and see whether parity is being enforced. And then there's, of course, what people can do in their personal lives with educating people. If there are people in your family who need help and help them, there are levels that people can get involved in. But if everybody did at least one of those things, we could really, really change the world. And we have the first opportunity, really, in the work, that we've been doing, saying, as I said, before, we never had the platform before where we could really make a huge difference. We could get some more money here and a law passed there, and those things were all important. But now we really have the chance to really change the whole paradigm in this country about how we deal with behavioral health and get people prevention and treatment. But it is going to take a lot of work for everybody to do what you can do.
Yeah, so I've got 4 takeaways. You can take your pick depending on which one you fit in. So number 1, for everyone, anyone can do this. In the state in which you live, ask the question, has guidance on implementing parity been issued in this state? And if not, make noise about why. And the place you can start is your state insurance commissioner's office. Most of them have what's called an ombudsman or a consumer advocate, and ask that question, because we've got to create demand for them issuing it. And when I say guidance, what I mean is the state insurance commissioner, who's a regulator over the health plans that sell insurance, and employers that sell insurance in your state, telling them what the expectation is for them complying with this law. So that's task number 1. Number 2, regardless of what setting you are, whether you're an academic person or in a nonprofit, as much as talking about webinars kind of makes everyone's eyes roll back in their head, there are tools if you need to educate the people with which you work. And I would say, especially if you're in the behavioral health field, if we aren't responsible for implementing this law, who is? So if you work with staff that don't know what the parity law is and what the rights and benefits are, get them trained up. And we have decks you can use. You don't have to start from scratch. I've got people that would help you on the webinar. So that's another thing you can do. If you're in recovery, talk about it. People like Patrick does a world of good because he talks about it. I talk about it everywhere that the opportunity will help. And like Patrick, it certainly helps me personally because I don't have to feel like I'm this 2 different personalities. The last thing I think is that when you're at your family reunion this summer, or when you go for your family beach trip, if someone in your family has a mental illness, even if it's just marriage counseling, or it doesn't have to be the dark, scary mental illnesses, talk to them about that. There's this law out there, and your copay should be less for paying for this stuff, and talk it up, because I think unless we kind of drill this down into the at the grassroots level and talking about this, people don't know. And, one of the things I've noticed in the years that I've worked on parity, I started early in the 90s, the needle has changed about people being willing to talk about this. It's not where it needs to be by any means, but it has changed, because I know when I first used to go around Capitol Hill and talk to policymakers like Patrick and their staff, they oftentimes after the meeting was over would say, okay, thank you, and we'd be off to our other meeting. They'd say, Carol, could I see you in my office for a minute, and pull me away from the crowd, and they would start whispering, I've got my mother has a problem, or I have my son who has a problem, and it would be in this whisper. And many of you, I'm sure, have had this happen to you. You'll go to a cocktail party, and someone starts whispering about the fact that someone in their life, and I have noticed the whispering has stopped. The calling in the back office has stopped. They announce in the middle of the meeting that someone in their life has this issue and they're interested, and they start, hitting you with questions about how their family member could get help. And that's what we need. So the more we can talk about it ourselves, the more it raises the ability for everyone else around us, because we teach people how to talk about these illnesses
But Carol,
by the way we do it.
Is there a conversation about this within the recovery community? I recently covered a big event here in Philadelphia. It was Narcotics Anonymous. And it felt like I was going to an undisclosed location with a bunch of FBI agents. I mean, they were like taking my cell phone. They were like, you cannot talk to anybody. You cannot photograph anybody. You cannot, like, don't even look at anybody. I mean, so I think it was you, Tom McClellan, who said to me, there are millions of people who are recovering successfully, in recovery successfully, but nobody knows who they are. And these people were very much into guarding that secret. So I'm wondering if that conversation is changing at all.
I think it is, and I think movies, documentaries like The Anonymous People are help raising the awareness that there are certain sacred traditions in mutual support and 12-step that affects things like the media being able to take pictures of people who are there. But there is a much broader community outside of 12-step world where you can talk about your recovery in any ways you want to and talk about the fact that you have this illness and you got well and your life is better than it was before, and I'm contributing to society in these ways. So I think that is changing, but there'll always be some sacred traditions in those programs, and I think you encountered one of them.
Dr. Evans, what's your take on what can individuals do?
Okay, so I have a disclosure. I've had the happy song in my head all morning. I can't get it out, so so I'm struggling this morning.
I'd like that struggle.
Yeah, I guess given what I could have going on, I guess that's not too bad. Yes. A few things. One is I think that. I think that the metaphor and the analogy of the civil rights struggle is so apropos for this, and I think the sort of the takeaway for me is that one of the lessons of the civil rights movement was that there were people who were very famous like Rosa Parks and other people, but there were a lot of people who were just into guerrilla warfare. They were being resistant in all kinds of places, and that's really what started to eat at the fabric of segregation. And I think in a similar way, trying to get back to this idea of culture, how do we change the culture? For people not to acquiesce when there's clear discrimination related to behavioral health conditions, and whether that's your own personal situation or a family member, I think not acquiescing and pushing back in those issues and those situations is important. Secondly, I do think that this issue of how do we create a culture of equity is really important. And there are lots of places, we've talked a lot about the legal and the financial. We have to deal with, if you're a treatment provider, how do we make sure that when people walk in through our doors in the treatment world, that they have an experience that's comparable to walking through a healthcare provider? And the reality is that sometimes that's not always the case. And so I think that the treatment world is going to have to step up. We're going to have to step up our game so that we can be viewed as equal players. And there are a lot of things that we can do in that realm. The last thing I would say is that I think that we have to behave in a way that's consistent with equity. And a lot of great comments here, but someone once said, I had a family member who had an addiction. No, they had a family member who had actually a physical health condition, and the neighbors came by and they brought the person a pie, and everyone was very supportive. When we have behavioral health conditions, it is hush-hush. People don't want to talk about it. We whisper. And I think as long as we continue to do that, we reinforce that there's something wrong with having a behavioral health condition. So I think I would challenge all of us to think and to stop and be very conscious about what are the unconscious, the nonverbal things that we do that communicate that there really is an inequity between having a physical health and a behavioral health condition, and to behave in a way that's consistent with I think what we've all been talking about today, which is if you do have a behavioral health condition, addiction, a mental health challenge, that you have the same right to treatment. And then I want to just make a plug, since you started. We really would like for people to participate, and I Will Listen. So I want to, again, encourage people to do that. We have places all over the city, and as Maiken said, it is a way of reducing stigma, or a campaign to reduce stigma. So if you can come by Love Park, that would be great. You can make the pledge. We'll take a video of you. It'll go on the website. So it's one of those things that I think is consistent with what we've talked about today, is how do we really reduce stigma and I think really celebrate the fact that recovery is possible.
All right. Congressman, we have about a minute or so.
Yeah, well, all the recommendations were fantastic, so I wanted to wait till the end because I knew they'd capture all of them. I like to just give some idea to what Arthur was saying about the civil rights. So my uncle Robert Kennedy gave a tremendously compelling speech in South Africa in 1966, and I think captures this notion that of what all of the my friends have recommended, and that's individual action. He said, each time a person stands up or acts to improve the lot of others, they send forth a tiny ripple of hope, and coming from a million centers of energy and daring, those ripples can create a current that can knock down the mightiest walls of oppression and resistance. And this was in 1966, and whoever imagined that you're going to have Nelson Mandela walk out of Robben Island and into the presidency of that country. So this is possible. We have to take this notion. It isn't up to someone else to do this. It's up to each of us to just do our part. And if enough people do it, and we break the silence on this, we can have equal social change in this area that's in dire need of social change.
Well, thank you all so much for your input and for the information. And I think Abigail is going to wrap things up, right? Okay.
I wanted to add one additional suggestion to the ones that the great panelists provided, and that is to support the organizations that are doing this work, that are on the grounds doing this work. There are a lot of outstanding organizations out there. This is a moment. So many people have said that today. This is a historic opportunity to affect the kind of change that many of us have been trying to affect for a long time. And by coming together, by working together as organizations, like TRI is working with Legal Action Center and with the Kennedy Forum and with the Parity Implementation Coalition, and the City of Philadelphia is working with NAMI and TRI. The more we can come together to do these things, the bigger the microphone we're going to have. And a lot of these advocacy points that we've been talking about, unfortunately, as Dr. O'Brien said, that's an area where funding is sort of sparse as well. So, we count on, I think, the community that believes this is going to happen to not only make noise, but to support the work of these organizations. So, that's one other thing that every one of us can do to move the field forward. I also wanted to mention that a lot of the states have state chapters of Parity Coalition chapters where you can report if you think that there's been a violation, or ask for advice if you think that there may have been a violation. So our local Parity Coalition works through the PROACT office, and you can contact them. You can look on their website, PROACT, or call them at 1-800-221-6333. And I also wanted to ask all of you, if you found the information that was presented today to be helpful, to fill out the evaluation forms. We're hoping to make this an ongoing activity, to continue bringing information to the public about the ways in which research can truly be translated, so that we can take advantage of the historic moment that we're in and create the impact that is deserved in this field. The next talk that we have will be given by George Koob, who is the director of the National Institute on Alcohol Abuse and Alcoholism. That's going to be same place on October 29th. We'll be sending out information to all of you, but please save the date. We'd love to see you all again. And last but not least, I just want to say thank you again to our outstanding presenter, the Honorable Patrick J. Kennedy, and our wonderful panelists, and thank them earnestly for being here today.
And thank you, Abigail, for pulling this all together. We appreciate it.
Thank you.